Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome back, CardioNerds. We are pumped to be back in Boston with some of our favorite friends. I'm with Dr. Susan Mcilvaine and Dr. Inbar Raber, and we are about to discuss a great case. But before we dive in, Susan and Inbar, would you like to introduce yourselves?
Sure. So my name is Susan Mcilvaine. I am a third-year cardiology fellow at Beth Deaconess in Boston. I will be working next year at Brown University as a general cardiologist. And I have an interest in women's health and cardio-obstetrics in particular and medical education.
And my name is Inbar Raber. I'm originally from California and currently a third-year cardiology fellow at Beth Deaconess Medical Center. I have a particular interest in preventive cardiology as well as echocardiography and medical education. And next year, I'm excited to be an attending at Leahy Hospital. I'm super excited to contribute to the CardioNerds episode and have really benefited from the podcast as a way to broaden my knowledge, even as a busy fellow. So appreciate your tremendous efforts in creating the CardioNerds community, and it's a wonderful resource for all of us.
Yes, totally agree. You guys have gotten me through lots of workouts and long drives.
Well, Susan and Inbar, you guys are too kind, and the whole CardioNerds platform thanks you for sticking with us and listening to us. And actually, before the recording, I learned that Inbar and I had actually met way back when she was on the interview trail for fellowship, way back when that was a thing, that you went to the programs that you potentially go to. So it is amazing to reconnect. We are in Boston. I love it at this time of year. It's crisp, it's clean, it's safe, and it's fun to walk around. But I'm just a tourist. You guys know what's going on. So where should we go and settle down so we can have a great chat about cardiology?
So we are going to take you just about a 5 or 10 minute walk from the hospital to Fenway Park. We actually get $5 tickets to Red Sox games with our hospital ID. We get 2 tickets for each ID, so we can get you in for $5. It might be a little bit loud for discussing our case, but that's where we're going to go.
Well, I think that's absolutely perfect. And we will be able to, we love cardiology so much. We'll be such nerds that like all we'll hear is going to be cardiology. And then as soon as we're done, we'll hear the game. It'll work out quite well. Perfect. So why don't we get started? Susan, I heard you have a very interesting case. Why don't you tell us a little bit more about it?
Okay, yes, let's get started. So I am going to start telling you about a 72-year-old gentleman who's a veteran who presented to one of our affiliate hospital emergency departments with 2 weeks of progressive dyspnea, orthopnea, nausea, vomiting, diarrhea, and right upper quadrant pain. So lots of symptoms. In terms of his past medical history, so he has a history of essential thrombocytosis, hypertension, a known left bundle branch block, Barrett's esophagus, basal cell skin cancer. He's had several of those removed over the years. He's had a right hip replacement. And as I mentioned, he's a veteran, so he actually has multiple areas of shrapnel in his body because he was unfortunately exposed to a mortar round explosion. In terms of his social and family history, so he's a retired postal worker and a former Marine. He's actually visiting his daughter in Massachusetts from southeastern United States, so he's only in town for a couple of weeks. He's a never smoker. He doesn't drink any alcohol, doesn't use any recreational drugs. His family history is fairly unremarkable, especially from a cardiac standpoint. His medications are metoprolol tartrate, 50 milligrams once daily, prazosin, 2 milligrams every night, hydralazine, 25 milligrams twice a day, omeprazole, 40 milligrams once a day, potassium chloride, 40 milligrams twice a day. He has no known drug allergies. So he presents in the emergency room. His initial vitals are notable for a temperature of 98.7. He's tachycardic with a heart rate of 116, and that's sinus tachycardia. His blood pressure is 136 over 87. His respiratory rate is 22, and he's satting 85% on 4 liters of nasal cannula. On exam, he's noted to be slightly tachypnic, but not in any respiratory distress. His cardiovascular exam is notable for tachycardia, but no murmurs. His abdomen is soft without rebound rigidity or guarding. He has no focal neurologic deficits, and he has scattered ecchymoses and petechiae over his extremities. His initial labs were notable for a creatinine of 1.43. Again, he's visiting from out of town, so we're not sure what his baseline is, but this could represent an acute kidney injury. He has a white count of 7.9, a hemoglobin of 13.1 with a hematocrit of 39.8, and platelets of 474. His AST and ALT are both 28. Alkaline phosphatase is 85. His T-billy is elevated at 2.35. His BNP is normal at 97. His troponin I went from 0.01 to 0.02 to 0.05. And normal value in this lab was less than 0.01.
So we have a patient with a whole constellation of symptoms. So he's a 72-year-old with dyspnea, orthopnea, nausea, vomiting, diarrhea, right upper quadrant pain. He's tachycardic with a heart rate in the 110. And he's also hypoxemic, requiring 4 liters of oxygen. And so far, we found that he has an elevated billy and an elevated troponin as well.
Yeah, this brings me back to internal medicine morning report. I feel like this is the type of case that you could go crazy on a whiteboard about, just sort of thinking about differential and different potential etiologies of his lab abnormalities and symptoms. I think this case also helps us remember and appreciate the good work that our emergency room doctors do because, again, he comes in with a pretty wide range of symptoms and lab results that don't necessarily fit together neatly. So I think initially the thought is, could this gentleman be infected? He's coming in again with nausea, vomiting, diarrhea. He's got right upper quadrant pain. Could this be sepsis? He's tachycardic. He could have a GI source of infection. He could have a pulmonary source of infection that's sort of causing some referred pain to the right upper quadrant. His lab work is interesting in that he's got an elevated T-billy, but his AST and ALT are actually normal. And he actually has no white count. His white count, again, is 7.9. So some things arguing for infection, others that sort of are in the no column for that one. And of course, this is the CardioNerds, so there's bound to be some cardiac issue. And he has mildly elevated troponin and he's tachycardic. But the troponin elevation, again, is mild and the tachycardia is sinus tachycardia. So that could be related to anything. He's coming in with symptoms that could be consistent with CHF. He complained of dyspnea and orthopnea, but his BNP is normal at 97. And again, that wouldn't necessarily explain, the right upper quadrant pain or some of the other symptoms that he's presenting with. Inbar, do you have any other thoughts on sort of the initial differential?
No, I think that the big things that we're really trying to rule out, we're kind of thinking about what are some of the potential emergencies, especially in someone that is tachycardic and tachypnic. So definitely thinking about, something like an infection. Also, I like to think about like a pulmonary embolism in this type of case. And so I'd really be thinking about getting some imaging as a next step.
Yeah, I agree with you, Inbar. And, just to add to what you guys have said, the skin findings are kind of interesting and a little bit perplexing. Scattered ecchymosis and petechiae all over the extremities. That's not necessarily something that I typically think of when I'm thinking about tachypnea and tachycardia, and thinking, let's say, about PE, for example. But when you're like dealing with, there's definitely something systemic and almost inflammatory in nature that's going on with this patient. We're seeing these skin findings without like the expected thrombocytopenia. So there's definitely something going on under the hood. And I'm definitely interested to hear what you guys ended up doing in terms of next steps of evaluation. So what were your next steps actually?
So he had some imaging done in the emergency department. So he had a CTA of the chest. And this demonstrated actually a couple of things. So a large pericardial effusion measuring up to 3.1 centimeters. He also had bilateral pleural fluid collections. The wording of the report was that the constellation of findings is concerning for congestive heart failure. Pneumonia cannot be excluded, but the basilar pulmonary findings favor atelectasis. And he also, on the CTA chest, had bilateral acute pulmonary emboli with some evidence of right heart strain. So lots on the CTA chest. And then he also had a CT of his abdomen and pelvis that showed possible cholecystitis with gallstones and gallbladder wall thickening with a possible pericholecystic inflammation. Yeah, so we have a CT chest, abdomen, pelvis that is showing the pericardial effusion, pleural effusions, bilateral pulmonary emboli, and possible cholecystitis.
Susan, that is a lot to find on imaging. So we do have some explanations for some of his symptoms here. So he does have gallbladder thickening, which could explain his right upper quadrant pain, his nausea and vomiting. He has pulmonary emboli as well as pleural effusions and a pericardial effusion, which could help explain his tachypnea, his hypoxemia, and his tachycardia as well. So on one hand, he seems to have a lot of different issues that might be totally unrelated. But if we're trying to think about a unifying diagnosis for someone that has pulmonary emboli, a pericardial effusion, pleural effusion, I'm really concerned about him having a malignancy. So I'm concerned about cancer or some other type of inflammatory process causing all of this.
Absolutely. And he certainly has risk factors as well to have cancer. As we mentioned, he had a history of Barrett's esophagus. He has multiple skin cancers that have been removed, and he has this essential thrombocytosis as well. So I think, if this patient were presenting to me in the emergency room, that's what I would be most worried about initially, would be sort of an underlying malignancy tying all of these findings together. The other thing to think about too would be an inflammatory process with pericardial effusion and pleural effusions. I'm not sure whether that would totally explain his pulmonary emboli, and I'm not sure whether that would explain the possible cholecystitis, but it could be the reverse order too, right? Like he could have an infection that caused an inflammatory state, and then that has sort of blossomed into some of the other findings on the CT as well. So still unclear, I would say, sort of the sequence of events here for this gentleman. Okay, so on CT scan, we have a large pericardial effusion, pleural effusions, and pulmonary emboli, and the patient presented with tachycardia and hypoxemia. The tachycardia and hypoxemia could be caused by lots of different things, including, just the PE or just the pleural effusions. But in terms of the acute findings on the CT scan, it's super important, of course, to rule out that he's in tamponade and that that's what's causing his tachycardia and his hypoxemia. And so the next step, of course, would be to get an echocardiogram to look for signs of tamponade.
So he underwent an echocardiogram, which showed normal left ventricular size, wall thickness, and systolic function. The right ventricle was normal in size, and the function appeared normal. And he had a large circumferential pericardial effusion with evidence of right atrial and right ventricular collapse, consistent with pericardial tamponade.
Yeah, and the images are pretty impressive when you look at them. I mean, this is not the type of echo overnight that takes a lot of back and forth to decide if the patient is in tamponade. You can sort of very plainly see the RA and the RV collapse here.
Yeah, I agree with you both. And looking at these echoes, like the other thing that you get is the chronicity of it, right? So you have evidence of tamponade, and I encourage everybody to check out the blog page for this episode where you can watch these imaging clips for yourself. But you can see that there's quite a sizable effusion. So, that tells us that, yes, sure, there ultimately was a pressure development within this pericardial space that is causing some hemodynamic changes and potentially one of the contributors to the patient's presentation. But at the same time, this process has been developing over time to develop that amount of fluid without an earlier presentation. Because as we know, small changes of fluid in the pericardial space could lead to tamponade. So when you see this much fluid in there, you know that this process probably has been brewing if this pericardial effusion is linked to this patient's presentation, which it most likely is.
Right. And he's tachycardic, but fairly mildly so. And his blood pressure has been stable. So I agree with you, Dan, that this was definitely building over time, given the amount of fluid that's there and the sort of lack of hemodynamic instability.
And one of the things we learn how to look for early on as cardiology fellows is how to evaluate for tamponade on echo. So thinking about how to obtain the images and interpret the echo findings. So we're really looking for, right atrial collapse in late diastole, right ventricular collapse in early diastole, and then also looking for respiratory variation in the inflow velocities across the mitral and the tricuspid valve. And so this is really because of ventricular interdependence. So we're seeing evidence of that on this echocardiogram as well.
So he started on a heparin drip for his pulmonary emboli and ertapenem for his possible cholecystitis. And he's admitted to the hospital with a plan for an urgent pericardiocentesis. So he undergoes pericardiocentesis and drain is left in place. They drained out 660 cc's of fluid that appeared red and cloudy. The initial gram stain was negative, and the cytology at this point was still pending. So on hospital day 3, he has minimal drainage from his pericardial drain, but a repeat focused echo demonstrated a moderate to large effusion still remained. So the drain was flushed and aspirated at the bedside, and ultimately only about another 30 cc's was able to be manually aspirated. His labs at this point have improved a bit. His creatinine is down to 0.8 from 1.4 on admission. His T-Billy has decreased to 1.08 from 2.35. His ANA comes back positive, but the titer is 1 to 40. And then pericardial fluid studies are fairly unremarkable, and the cytology comes back with no malignant cells. The following day, the patient is febrile to 101.5 in the morning. He still has ongoing mild tachypnea and a 4-liter O2 requirement. And at this point, the team taking care of him initiated a transfer to our institution for further management and possible pericardial window, given that he had decreased drain output, but an ongoing effusion on echo.
On arrival to our hospital, he continued to be febrile to 101 with ongoing tachypnea. We still found no evidence of infection, and actually his CT abdomen was reread as cholelithiasis without evidence of cholecystitis. At this point, we're trying to think about a unifying diagnosis for him for the pericardial effusion, the pleural effusion, and the pulmonary emboli. And we were still very concerned about an occult malignancy, even though he underwent CT chest and CT abdomen and nothing was found yet. He also had the pericardial cytologies. Those do have limited sensitivity. So in a retrospective study of about 173 patients, the cytologies are only positive in about 50% of patients who had malignant effusion. So even with the negative cytologies, we were still pretty concerned about that. And then I can talk about, if we were to think about a broader differential diagnosis for the pericardial effusion, so kind of taking a step back and thinking about a broader differential diagnosis for pericardial effusion, there are so many different etiologies that it's helpful to group them into smaller groups. So I usually think about metabolic, malignant, medications, trauma, rheumatologic, infectious, and cardiac emergencies. So metabolic could include things like renal failure or thyroid disease. Malignant lung cancer is the most common cancer to spread to the pericardium, but other cancers can do so as well, including leukemia, lymphoma, breast cancer, sarcoma, and melanoma. For medications, immune checkpoint inhibitors can cause both myocarditis and pericarditis. And then medications associated with drug-induced lupus, like propanamide, hydralazine, toin. And then I also include radiation therapy here. So it's not a medication, but it's an iatrogenic cause of pericardial effusion. For trauma, I think about blunt chest trauma or cardiac surgery or catheterization. Rheumatologic causes are important, such as lupus, rheumatoid arthritis, and systemic sclerosis. And infectious is a really big category. So that can include viruses, bacterial causes like TB, or fungal causes, which have a really high morbidity and mortality. And then finally, cardiac emergencies, such as aortic dissection or myocardial infarction. And so a lot of these can really be ruled out by his testing so far, including the labs and the imaging. So I think we were still thinking about malignant causes and then rheumatologic or kind of inflammatory causes as well. We consulted interventional pulmonology, placed chest tubes, and 650 cc's of fluid was drained. He was found to have exudative pleural effusion.
Wow, Susan, Inbar, this is a very profound presentation. We have this patient who presents basically with this, at this point, seeming like inflammatory milieu with the pleural lining inflamed and an exudative pleural effusion. We have the pericardial effusion. We have these fevers. We basically are seeing like a super systemic inflammatory reaction. And unfortunately, our patient is suffering. So what was the next steps in management and kind of like what was the course for this? And did you do any advanced workups in terms of the rheumatological space to kind of tease out what may be going on?
So we actually benefited from some of the initial work that he had in the emergency room. So he had a few pending tests that came back, including a positive anti-histone antibody. And he also had a negative anti-double-stranded DNA.
Anti-histone antibody, isn't that like a USMLE board pearl for hydralazine-induced lupus? Do I have that right?
You do have that right. So we don't know who it was, but somebody thought about this item on a differential and sent an anti-histone antibody before he was transferred to our care. And, we were following up the result mainly the cultures and things from the outside hospital. And then this anti-histone antibody came up as positive. And we had mentioned earlier that his ANA was positive, but it was, the titer was 1 to 40, which we always see and don't really know what to do with. But now we have a positive ANA and a positive anti-histone antibody, which, as you mentioned, Dan, is related to drug-induced lupus.
Just for the record, for the listeners, I did know that before this podcast recording. It was one of those heavily tested USMLE pearls way back when.
Yes, that's something that's in all of our brains somewhere, but, only emerges when we're prompted with something.
Like a board exam. Actually, drug-induced lupus and systemic lupus can be hard to differentiate because they have a lot of similar features. So both can present like this patient with fevers, myalgias, or arthralgias, rash, pericarditis, and pleural effusion. But in drug-induced lupus, you would see a positive ANA, rheumatoid factor, an anti-histone antibody. And in systemic lupus, you typically see a positive double-stranded DNA, and that's usually negative in drug-induced lupus. So that kind of helps cinch in the diagnosis as well.
Yeah, and it's kind of interesting. The incidence of drug-induced lupus with using hydralazine is fairly high. So depending on sort of what sources you look at, it approaches 10% of all patients that are treated with hydralazine. And there are other cardiac medications as well that are implicated. In particular, procainamide has an incidence of 15 to 20% of patients treated with that medication can develop drug-induced lupus. The other thing too, I remember talking to one of our rheumatology fellows about this. Oftentimes, somebody who's taking hydralazine, if you do a serologic analysis on them, they'll have positive anti-histone antibodies and positive ANA, but they may not have any symptoms attributable to drug-induced lupus. So I'm not sure whether that 10% includes symptomatic people or people who have positive serologies when you check them for drug-induced lupus, if that makes sense.
One reason why hydralazine-induced lupus can be difficult to diagnose is that unlike other adverse effects for medications, which occur instantly, the onset is usually much slower. So it's on the order of months to years. So if you ask the patient about any recent new exposures prior to their symptoms, they likely won't think about a medication that they've been on chronically.
Yeah, that's a great point. This guy had been on hydralazine. His medication list is otherwise pretty benign looking, right? Like hydralazine, metoprolol, prazosin, omeprazole. So he's not the type of patient that I would necessarily pour over his drug list to look for things that might be causing issues.
Exactly. He'd been on hydralazine for years. So, usually people would think, okay, this is all kind of a chronic medication list and wouldn't go exploring that any further.
Yeah. His hydralazine actually had also been up-titrated during the hospitalization for better control of hypertension. I don't think that had anything to do, obviously, with his symptoms because he, had the symptoms before the up-titration, but that's how far off the radar this diagnosis was. We were up-titrating the medicine that was causing the issue.
Oh, wow. You have talked about drug-induced lupus versus non-drug-induced lupus earlier. And now that we do have a unifying diagnosis of hydralazine-induced lupus, is the prognosis better with a drug-induced lupus versus just lupus due to autoimmune disorder, NOS?
Yeah, that's a great question. So the treatment for drug-induced lupus, it's really extrapolated from systemic lupus. So in mild cases, the first step is just to remove the offending agent. And sometimes that's enough actually for symptoms to resolve. In mild cases, sometimes NSAIDs are also used, which can be accompanied by hydroxychloroquine. And then in more severe cases, such as those that get pericardial effusions, pleural effusions, like our patient, usually systemic steroids are used initially. So for this patient, we had consulted rheumatology once we made the diagnosis of drug-induced lupus, and they had recommended initiation of systemic steroids.
So once he initiated the steroids, he started to improve symptomatically. He was weaned pretty quickly to 2 liters of nasal cannula with some improvement in his dyspnea, and he was called out of the ICU out to the regular medicine floor. So the patient had a repeat echocardiogram performed, and this showed a very small circumferential effusion with some evidence for early effusive constrictive physiology. This is a whole different animal that we won't have time to address on this episode, but there have been lots of other CardioNerds episodes that focus on constrictive and restrictive physiology. So if you have questions about that, you can check those out as well. But we're going to leave that for now. The patient was discharged with a 1.5-month prednisone taper and colchicine with rheumatology and cardiology follow-up prior to returning to his home in North Carolina. So the patient was discharged with a 1.5 month long prednisone taper, and we set him up with good follow-up here in Boston within a couple of weeks with rheumatology and cardiology, and then provided him with some recommendations for cardiologists closer to home to continue following with, especially given that his echocardiogram was consistent with some constrictive physiology.
And after this patient was discharged from the hospital, one of the things that we, I think, really reflected on as a team was thinking about how broad of a differential diagnosis we really need to be thinking about for someone that comes in with a pericardial effusion. At first, we were really trying to come up with a unifying diagnosis for this pulmonary embolism and the pericardial and the pleural effusion. And we sort of anchored on malignancy, and that was our primary concern. Whereas he actually ended up having a completely different etiology for the pericardial effusion. So, I think one thing I really took away from this case is to not close out other potential diagnoses, especially when a patient comes in and is transferred in with such undifferentiated symptoms.
Yeah, I think it's totally reasonable to rely to an extent on our heuristics that we've developed and, common things being common. And we've seen these types of presentations multiple times throughout our training, but, we have to keep the zebras in mind and keep our differentials broad when a patient, like you said, Inbar, is still undifferentiated. And so that brings us to a couple of learning points specific to our case. So in terms of presenting with pericardial effusions and their relationship with malignancy, like we said, we sort of anchored on malignancy as a potential diagnosis here, which is not totally unreasonable given that about a third of patients who present with a hemodynamically significant pericardial effusion do have an underlying malignancy. And so a third of the time you're going to be right if that's what you decide to hang your hat on. But 2/3 of the time, that's not the case. And so we have to keep the other items on the differential in mind. The other thing to keep in mind about pericardial effusions and malignancy is that in malignant effusions, cytology is actually only positive half the time. So again, our CCU team, even though the patient's cytology was negative, we're still sort of considering malignancy as the top item on the differential. The other learning points from this case with respect to drug-induced lupus are that, number one, hydralazine is commonly implicated in drug-induced lupus. It's a drug we prescribe all the time, but like we mentioned, the incidence is around 10% of patients treated with hydralazine will develop on the spectrum of drug-induced lupus. The other medication that we prescribe that is associated with drug-induced lupus is procainamide. So the risk is pretty high with both of these agents. So I think going forward, if I have a patient coming in who is on chronic hydralazine, who has new pericarditis with or without a pericardial effusion, I will think about drug-induced lupus for sure, even though we didn't necessarily think about it right away in this case.
And that's such a good point, Susan, because we rely so much on the lab testing to make the diagnosis. So we're not getting double-stranded DNA and anti-histone antibodies in every patient, but in the right patient, it makes sense to send those. Otherwise, we'll miss many of these rheumatologic diagnoses in our patients.
Absolutely.
Well, thank you so much, Susan and Inbar. We really appreciate you letting us visit you guys in Boston and learning about this important case. And of course, when patients come in with PE or tamponade, we definitely have to treat the most urgent needs and sometimes spread the diagnostic net and see what we catch later. And that's kind of what you did. And then also, we saw this patient was initially started on broad spectrum antibiotics. And as time progressed, the time is sometimes the best diagnostic tool. And while we did ultimately rely on lab findings to help pinpoint the diagnosis, the time course and the tempo of the patient's pre-hospital presentation and then hospital presentation was very informative of what we're looking for. And so we know that if we keep our spidey senses up and while we look for the common things that are common and treat the things that are urgently life-threatening, but also keep our minds open, we'll be able to save our patients or at least help save our patients in the acute setting, but also not miss diagnoses that we have to catch before we change course in treatment, like with, in this case, where we're going to use anti-inflammatories instead of antibiotics and so on. So thank you so much for highlighting this really, really important entity. And we really appreciate your patience for teaching all of us this very important lesson.
Thanks for having us. This was fun.
Yeah, thanks so much for having us.
What a fantastic case discussion. Now let's build on that with an expert commentary from Dr. Dino Kazi. Dr. Kazi is a rheumatologist, professor of medicine, vice chair of education, and program director for the internal medicine residency training program at UT Southwestern. As you'll see, he is also a master clinician and educator, and we are so honored to have his perspectives here on CardioNerds. Thank you, Dino.
Well, hello, everyone, and thank you for the opportunity to reflect on this really fascinating case presented by you. As I think about it, the diagnosis in retrospect seemed so clear, but as the patient presented, I'm glad that there was an understanding of the many causes of pericardial effusions, and then trying to tie that up with the pleural effusions and the abdominal symptoms to think of a systemic inflammatory disorder was the logical approach. Interestingly, the patient wasn't febrile to start with, but then did develop fever. And the failure to improve with supportive care and antibiotics was fairly classic for an offending agent that was causing these problems that ultimately improved with the institution of corticosteroid and withdrawal of the agent. The improvement was actually quite dramatic. So quite rightly so, you made I'd say, fairly high probability diagnosis of drug-induced lupus. So drug-induced lupus always comes as a surprise. It comes as a surprise to rheumatologists as well. We also sometimes have difficulty separating it from idiopathic lupus because the serology is often very similar. There are some subtle differences which I will go over with you. The patient was on what's called a high-risk medication. Both hydralazine and procainamide have the highest risk of all the drugs that do cause or are associated with drug-induced lupus, at the order of about 10% or so with hydralazine, which was the medication this patient was on. Procainamide, interestingly, even though it's used much less now, quite reliably can cause positive autoantibodies. Up to 90% of patients will develop a positive ANA after 2 years of being on procainamide, but not everybody will go on to develop drug-induced lupus. So the antibody itself is insufficient to make the diagnosis. This patient had a pericardial effusion, bilateral pleural effusion, and also had some abdominal symptoms, which makes me think that the patient might have had serositis as well, which, as you know, is a feature of lupus. The patient had positive anti-histone antibodies, which are quite characteristic of situations where you're considering drug-induced lupus. But it's important to remember that anti-histone antibodies can be seen in idiopathic lupus as well. When I've thought about drug-induced lupus, I've also learned over the years and through my training that the CNS and the kidneys are generally spared. You can get, cutaneous findings. I also want to emphasize that there is another variation of drug-induced lupus, which involves mainly the skin, and it typically follows the clinical pattern that you will see with subacute cutaneous lupus erythematosus, or SCLE. And a slightly different group of drugs is associated with terbinafine and omeprazole. Interestingly, this patient was on omeprazole, although I don't think it was the cause of this patient's pericardial effusion, which most likely was hydralazine. When managing these patients, you have to manage the organ dysfunction, which was relatively easily achieved in this patient after you took care of the initial emergency of the tamponade with corticosteroids, and the very rapid recovery is sort of quite characteristic. I hope that with the tapering of the steroids that this will not recur. Sometimes it takes some time to be completely free of the effects of the medication, and patients may need a longer steroid taper. Some patients even need hydroxychloroquine, but most patients will improve, and the prognosis of this disorder is relatively good. The other drug that I want you to be aware of, mainly because it's used quite a bit, is minocycline. And minocycline has been used in patients with acne. And so young women on minocycline are at risk of drug-induced lupus from minocycline. It's less likely to cause things like pericardial effusion, but skin lesions, fever, and joint pain are quite characteristic. Other drugs that have been associated with drug-induced lupus include the TNF inhibitors as well as the checkpoint inhibitors. The list actually is quite long, but the high-risk drugs are the ones that you've highlighted here, procainamide and hydralazine, and to some extent, phenytoin. The medium-risk drugs are probably terbinafine, some calcium channel blockers, beta blockers, and low risk, probably omeprazole. It's also important to understand that hydralazine can also cause a positive anti-neutrophil cytoplasmic antibody, and that can cause an sort of a drug-induced ANCA vasculitis. I don't think that was going on in this patient. I am uncertain if the petechia and the ecchymosis were in any way related to a cutaneous vasculitis from drug-induced lupus. Skin biopsy might have been helpful. Interestingly, the patient had a diagnosis of essential thrombocytosis, and his platelet count, if anything, was not low. The acute kidney injury with a creatinine of 1.43 with an unknown baseline seemed to improve spontaneously even before any corticosteroids were given, and the creatinine, improved to 0.8, which was helpful. In patients with drug-induced lupus, you're not going to see low complement levels. I think those are unusual. And most of the time, you're going to have a positive ANA, a positive anti-histone antibody seen in about 95%. And sometimes you'll have a positive double-stranded DNA. Positive double-stranded DNA has been associated with serositis, of course, also with the kidney disease, which this patient did not have and is not expected to have. I'm glad that the patient got better, and I'm glad that the diagnosis was made, but I'm also grateful that all other diagnoses were considered, because you wouldn't want to miss a malignancy or an infection. So again, my name is Dino Kazi. I am professor of medicine at UT Southwestern Medical Center in the Division of Rheumatic Diseases.
Thanks for tuning in to another CardioNerds episode. The audio editing for this episode was performed by me, Pacey Wetstein. I am an intern in the CardioNerds Academy, House Jones, and an MS1 at LeComm Seton Hill. I invite you to check out the episode page for show notes and references. If you found this episode informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our upcoming episodes. And now, it's time to make like an S2 and split.